Welcome, everyone. We'll have another great guest today, Dr. Carla Sharp. Dr. Carla Sharp is director of the Developmental Psychopathology Lab over at the University of Houston. She has her Ph.D. from the University of Cambridge, United Kingdom. And today, Dr. Sharp is going to talk to us about borderline personality disorder. So we're continuing exploring this fascinating personality disorder. Before we get started, make sure if you want to support our podcast to share and subscribe. Hit that like button. It really helps us out. So let's not waste any more time. Welcome to the show, Dr. Carla Sharp. Welcome, doctor.
Thank you. I'm glad to be here.
Well, this is great. Thank you so much for being here. It's a fascinating topic. A lot of people they've heard of borderline personality disorder. I don't think it's reached the misinformation level of bipolar yet or psychopath, where everybody just kind of throws it out. But I have seen it on occasions being thrown out where this person's borderline. I wanted to start off this episode if you could define borderline personality disorder, then we'll get into all your work.
Sure. So defining borderline personality disorder is actually a little bit complicated because at the moment we have 4 approaches to defining borderline personality disorder, and I will start with the most traditional approach, which we call the categorically defined disorder of borderline personality disorder. And what we mean with categorically defined is that borderline personality disorder, like many other psychiatric disorders, have to meet a set of criteria to be considered personality disordered. And so those criteria are really 9 criteria. It's intense anger, affective instability, it is impulsivity, emptiness, identity disturbance, self-harm and suicidality, dissociation and paranoia, abandonment fears, and then unstable relationships. So those are the 9 criteria for BPD as it is traditionally defined in the DSM-5, Section 2. And that is how most clinicians will still think about BPD. However, in recent years, since the publication of the new DSM-5, which happened in 2013, that is the DSM-5, an alternative model for diagnosing personality disorder in general and BPD in particular was put forward. And this alternative model takes a slightly different approach to personality pathology. And it suggests that we consider all personality disorders as sharing a common core, and that it becomes less important to define the flavor of any particular personality disorder, but more important to just be able to diagnose that someone has a personality disorder in general. And to do that, you look to 2 criteria. The first criterion is maladaptive self-function, and the second criterion is maladaptive interpersonal function. And maladaptive self-function is made out of problems in self-directedness and identity, and maladaptive interpersonal function is made out of problems in intimacy and empathy. And then once you've made that diagnosis, you can go on and define a particular flavor for the personality pathology. And that's done with 5 maladaptive trait domains. So borderline doesn't even feature for that second phase of the diagnosis. Then the clinician can do a 3rd phase of the diagnostic process, and that is then to specify BPD. So that's the alternative model for borderline personality disorder and for personality disorder in general. This approach to diagnosing personality disorder was picked up by the new ICD-11 system as well, which will take effect in 2022. And this is, of course, the European or the worldwide classification system. There it mirrors this alternative model very precisely, actually, with BPD actually being a specifier that just is a sort of a pattern that can be identified for general personality pathology. So all that to say that I do think the construct of BPD indexes something very important and clinically meaningful, but the definition of it is in flux. And we'll have to look to the future to see if the old construct of BPD will actually be maintained as we have known it for the last 50 years or so.
Fascinating. Wow, I didn't realize it was going to be that complicated. That's interesting. So I know BPD's changed a lot over the last several years. 10 years ago, really didn't have much of success in treatment, maybe 15 years, I can't remember now. Time flies as you get older. But things have changed a lot. Now they're starting to get more success with the DBT and Marshall Linehan and the rest of the gang that's coming out and doing a lot of work. I think the other one is Gunderson?
Gunderson, that's
Gunderson.
Right. Yes.
Yes, Gunderson's got a lot of work doing that. So that's why it really fascinated me, because as I've taught psychopathology and criminal psychopathology, I'm looking at BPD and going, this isn't the same thing almost anymore. It's starting to change right in front of my very eyes.
Right.
Go ahead.
Yeah, no, it was originally in the 1930s, the term borderline comes from trying to capture a kind of pathology that lies between what folks would refer to as neuroticism on the one hand and psychoticism on the other hand. Now, if you think about neurotic disorders, they're really depression, anxiety, substance use, and so forth. And the psychotic disorders, of course, something like schizophrenia, and borderline was coined originally to express some kind of pathology that's more severe than neurotic disorders, but not quite as severe as the psychotic disorders. And then, it was picked up in the DSM-3. It was the first time that it was actually defined. John Gunderson played a big role in defining BPD at that point. But it has morphed into this more general index of personality pathology over the last few years, alongside all of the incredible advances that have been made in treatment and then also early identification and prevention of BPD.
Yeah, really fascinating stuff. And one more question before we get into it, because I know we're going to be talking a lot about the developmental, the relationship between the developmental stages and early childhood and your work with adolescence and BPD. Before we get started with that, what's the comorbidity of it? I've talked to other people. I've heard ranges between 15 to 20%, which I know is hard to quantify, but with antisocial or psychopathy. What do you know about that?
That's a really important question, because one of the reasons we are changing the construct of BPD is because of its high comorbidity. So really, the estimates for BPD and comorbidity with anxiety and depression can be upward of 60–70%. And most people with BPD would have anxiety or depression as a comorbid disorder, and most people with BPD will have some kind of comorbid substance use disorder. And so it's this very high comorbidity that suggested to us that BPD is really a confluence of these neurotic disorders, and really indexes something very general about how our personality functions. So it's not that it is the same as internalizing and externalizing disorders, anxiety, depression, and substance use. It is qualitatively different, but it's a confluence. It stands on the legs of anxiety, depression, and substance use, and we also see that developmentally, which we'll get into a bit later.
Wow, that's amazing. That's pretty high. I didn't think it was going to be that high for depression. Makes sense, though. Makes sense. So tell us a little bit about how you got in started with the BPD in adolescence, but maybe we can begin with childhood. And a lot of people say this is a disorder that is more environmentally created?
Well, I think in the, perhaps 20 years ago or so, BPD would have been considered a purely environmental disorder, but there's now actually quite a bit of data to support what we call a diathesis stress model for the development of BPD. And that means that children come into the world with a particular temperament. They come into the world with particular vulnerabilities. And so when we do assessments in little babies, we know that babies already show individual differences in their temperaments. Some babies are babies that easily approach new stimuli. They like and they're interested in the environment around them. Other babies are more introverted and they tend to avoid stimuli, new stimuli, and they tend to be harder to soothe. They may be a little bit more impulsive. And so from day one, babies come into the world with a particular sort of temperament. this temperament interacts with the environment. And as these sort of interactions progress, these temperamental traits morph into what we would call personality traits. And we all lie on a dimension of higher and low neurotic traits, negative affect traits, inhibition, and so forth. Now, when we think about the environment, what is really critical is that the environment matches the temperament of the child. And so there was a time, like in schizophrenia and in autism, where parents were blamed for the development of the disorder, and that view has been discredited. And this is because some babies ask more of a caregiving environment than other babies. And so it's not really the parent who is necessarily a bad parent, but that there is some lack of fit between the temperament of a child and its parent. So you will hear accounts from parents who have 2 or 3 children. One child ends up having BPD and 2 children don't. And that is because there was a better or closer temperamental fit between 2 of the children and the parenting style in the household than one child who was particularly sensitive and needed perhaps more from the environment, and for whichever reason parents couldn't provide that. So there used to be this idea that all people with BPD were sexually abused or were physically abused, and that's also been discredited. The majority of people with BPD have experienced trauma, but some of that trauma may be due to an interaction between their sensitive temperament and their caregiving environment, rather than outright bad parenting behaviors by parents or caregivers.
Fascinating. I'm telling you, it's changing in front of my very own eyes. So that brings up about 4 or 5 different questions. Now, you mentioned temperament. It seems like the 5-factor model might be a little too simplistic, or is that applicable at all here?
Well, it is absolutely applicable. So you are right on. You know, when I said earlier on in the alternative model for diagnosing personality disorder, we first diagnose maladaptive self and interpersonal function, and then we give flavor to the personality pathology. And we do that through the 5 maladaptive trait domains, and those 5 maladaptive trait domains map onto the 5. So all of those ocean, we grew up knowing about ocean and openness and extroversion, introversion, and neuroticism and so forth. So those maladaptive 5 trait domains are actually just maladaptive streams of the big 5. And so absolutely, that is how we can then give flavor to particular personality pathology through looking at the trait domains. However, I have written a lot about this now. Traits are not enough to diagnose personality pathology. So we can have, for instance, there was a nice study once that looked at the trait function of Ted Bundy. And when you look at the trait function of Ted Bundy, he turns out to be actually quite extroverted, quite conscientious, and low in neuroticism. That trait constellation is almost exact replica of the trait constellation of very successful leaders. And so we can have 2 people who have the same trait function, but one would be a serial killer and the other would be a very successful leader. And so what brings the difference is really motivation and values. So there's more to personality function than just traits. And Dan McAdams has written very nicely about this, that a second level of personality function that we need to consider when we want to understand personality function is values and motivations. Why do people do stuff? And for that, we need to dig a little bit deeper than traits. There's a third level of personality function, which is narrative identity, which actually developmentally only comes online in adolescence. So when we hit adolescence, we are able for the first time cognitively to sort of step out of ourselves, look back at ourselves and think, who am I as a person? Where did I come from? Where am I at right now? And where do I want to go? Cognitively, children don't have that capacity until adolescence. And so that becomes a third very important ingredient in our personality function, so that we can have people with the same level of disinhibition and emotion dysregulation, the same level of traits, but they tell a different story about themselves. They've made sense of their traits, they manage their traits, they don't see themselves as defective because of these maladaptive traits, but have somehow managed to craft a story or a narrative for themselves that is adaptive and healthy. And they can go on to have a life like any other person without personality disorder. But so it's really those three levels that will interact over time: the trait level, motivations and values, and then narrative identity. And those together form our personality, and together must become disordered. So I think those big five traits are not enough to capture personality disorder. And we really need that first criterion, what we call criterion A, or level of personality functioning, maladaptive self and interpersonal function. We really need that criterion to decide, is this person high in traits but managing it well, or are they high in traits and have developed a defective story about who they are as a person?
I definitely supported that argument. That's for sure. I guess that's always been the knock with the 5-factor model, right? It's always been a little bit limited in its capacity.
That's
Society
right.
likes it. Society likes it. It's nice and easy.
Yeah, it's very intuitive and it can be replicated so easily, and but it really just isn't enough to capture everything about personality that helps us predict outcome, because that's where the proof is in the pudding. You know, you want to be able to predict outcome. You want to know who will hurt themselves, who will kill themselves, who's going to go to jail, who will respond to treatment and what sort of treatment. And so we need a more robust predictive model for predicting outcome than what traits can provide.
It's fascinating, especially when you mentioned Bundy's. I do a lot of work in the criminal psychopathology world. So when you talked about Ted, it was interesting because he's an interesting character. We'll just say that.
Yes.
Very fascinating to study. Kind of to go back a little bit again before we get to the adolescence stage. Do we notice anything with endocrine disruptors at all? And I've done a lot of interviews now with different professors and doctors around the world in regards to the placenta, the endocrine disruptors, and complicated births and trauma at birth and all that. What do we know about that?
There are some, just a very emerging literature. Sheila Crowell is actually someone, I think, leading the charge in that respect. Who is looking at endocrine or early, even before babies are born, what is happening in the womb, and are there kind of these stress factors that are related to BPD in particular. And related to that, one of the neurobiological or psychophysiological systems that are implicated in BPD is, of course, the HPA axis. So anything that is going to mess with the HPA axis prenatally or after babies are born, our ability to respond to stress effectively, that is going to have implications for BPD. But I don't think it's as simple as that, and there's not a whole bunch of, so I think as far as hormone function relates to HPA axis, we will see effects, but there is no real hormone theory of BPD as such. We do know, like most psychiatric disorders, BPD onsets in adolescence, and surely hormonal changes will play a role in that, but it's not been studied and it's not well defined at this stage.
Interesting. I guess the reason it brings it up, I'm not sure, are you familiar with Dr. Alan Shore?
Yes, I am.
Okay. Yeah, something I think it popped up in my mind. I know with him, it led me into a lot of different areas of interviews when I read about his affect regulation. And
Yes.
just when you mentioned now, a child that might be a little bit not connected, I guess, properly to the caregiver, made me wonder about Shore's affect regulation theory and right brain to right brain. Anything there?
You know, it's not being brought into relation with BPD or personality function in particular, but it is probably a viable avenue to explore, given that emotion dysregulation is a core feature of BPD. My own view is that the emotion dysregulation features associated with BPD are downstream effects of the primary problem in BPD, which is maladaptive self and interpersonal function. So the way I see it is that the early caregiving environment is a laboratory for children to practice the serve and return between humans. If you think about human interaction as a sort of ping pong game, and that we have to have the skills to regulate that ping pong game so that we both stay in the game, as it were. We both have to be able to stay in the game, and the ball shouldn't be ping ponged off the table. What people with BPD really struggle with is staying in the game and staying calm enough for us to play out the serve and return in a calm and measured, thoughtful way. And so the idea is that young children who, for whatever reason, don't get that practice in an early caregiving environment to practice the serve and return, some of them may shut down and may not want to think about the mental states of the caregiver for whatever reason, or they just don't flex those muscles that helps them learn how to deal with the serve and return. And that has a knock-on effect on self-development, because we use the interpersonal environment to learn something about ourselves. And if we're not able to manage or regulate the interpersonal environment, our self-development goes awry, and we end up with an unintegrated personality structure. So for me, the emotion dysregulation issues are downstream effects of this more primary broken self and interpersonal system that is supposed to regulate our interactions and relationships with other people.
I got so many questions. We just don't have that kind of time, but a lot of questions have popped up. Let me get to your theory, and then we'll go ahead and I'll ask some of the other questions later now that you've mentioned some things here that triggered it. Tell us a bit about adolescence, diagnosing BPD in adolescence.
Sure. So I would say probably about 10, 15 years ago, the diagnosis of BPD or any personality disorder in adolescence would have been frowned upon. And there were good reasons for the reluctance. The biggest reason was that clinicians often felt that they would be stigmatizing a young person with a sort of death sentence, because BPD and personality disorder in general, like psychopathy or antisocial personality disorder, they are highly stigmatized disorders. And the idea was that personality is not really fully formed, in a 15-year-old or in a 14-year-old, and therefore it would be very stigmatizing to label someone with that diagnosis if their personality hasn't been fully developed yet. So those were the major concerns. And the other problem was that we really viewed personality disorder as very stable and intractable. We used to see personality disorder as something that cannot be treated. It was stigmatized even among healthcare professionals. So, people would be saying mean things about their borderline patients, and it was really due to a lack of data. Since that time, we have learned many different things about BPD. We have learned, number one, that BPD is treatable, and there's 75 randomized controlled trials that have now been conducted for BPD, and we know that BPD can be effectively treated. We've also, in follow-up studies, discovered that BPD is not as stable as we thought. People move in and out of the diagnosis just like they do move in and out of depression or anxiety. It's much more syndrome-like in that sense than previously thought. People used to think that it's part of your personality and therefore it never changes, but it's actually not the case. The other big piece of information is that personality traits in youth are as stable as they are in adolescence and in adulthood. And so there is no that idea that somehow personality traits are not stable in young kids or in children, that went out the window. So we can now start thinking about early intervention, because we can look at which kids tend to be high on some of these maladaptive traits and which kids are struggling to integrate multiple hypotheses about themselves into one coherent and adaptive story about themselves. And we can begin to then intervene early with those kids. I mean, the other thing that we've learned is that there is this biological basis to BPD and personality disorder to the same extent as other disorders. The heritability of BPD is around 50% as it is for most psychiatric disorders. And so I think those were the myths hanging around in 10, 15 years ago. And I remember having a conversation with Andrew Channon, who is also one of the leaders in this area. And he said something very important, which was that if we treat BPD as different from other disorders, we as mental health professionals stigmatize it. So we actively started changing the narrative in the field to say this is a treatable disorder. It's not as stable as people thought, but it is equally stable in kids and in adults. And let's just name it and treat it and prevent it. Why does it have to be something special compared to other disorders if it has the same heritability estimates, if it can be treated? And so forth. And so, we have tried wherever we can to invite clinicians not to stigmatize the disorder further by whispering about it or diagnosing it, but not putting it in the chart or not telling parents about it. So a clinician will think a 15-year-old is very borderline, but would not tell a parent. You would never find a doctor thinking that a 15-year-old is diabetic and not tell the parent that they are thinking that there's untreated diabetes here. So I think for all of those reasons, the field has shifted to name the disorder, treat it, and prevent it.
That's a great point. Great stuff. A lot of good stuff. Let me ask you this: gender biases, are there anything there? Do we see it more prevalent among males and females?
We used to think it's a female disorder. It turns out that the conclusion was based on who seek treatment. So it is true that in treatment-seeking settings, there are more women seeking treatment for BPD and all personality disorders for that matter than men. But when you go into community-based samples or large epidemiological studies, the prevalence rate is more or less the same. There are some criteria that are more endorsed by women than men. So men tend to endorse the impulsivity criteria more than what women do. Women endorse perhaps some of the internalizing features of BPD more, but we now know that it's more or less an equal prevalence between women.
Interesting. I'm going to ask you a question. It's going to have another question hidden inside of it. About BPD in the sense of collective and individual societies. We didn't mention brain structures either, but I know there's some brain structures that are different actually in collective individuals who come from collective societies compared to individuals from individualistic societies. There's some differences in the brain structures in certain areas. I think one of them was the medial prefrontal cortex, I think, and the insula. Do we know anything about that?
Well, that is an excellent question. And I do think the cultural differences in personality disorder within the United States is very important next frontier for personality disorder research. There really isn't enough research that look into cultural different manifestations of personality disorder in the world. I do think we've started scratching the surface. This whole idea of criterion A, maladaptive self and interpersonal function, is going to be very culturally loaded. My hypothesis is that that's the more culturally loaded component of personality function, while traits may be more living inside biology because it's so tied to our temperamental function. But as you point out, even in our biology, there may be slight differences in cultures. So I do think the idea of collectivist versus individualist cultures for especially criterion A, maladaptive self and interpersonal function, is going to be very interesting to track. No data thus far, but we all know that we relate differently to people in different cultures. I have lived in 3 cultures: South Africa, where I grew up, England, where I did my PhD and postdoc, and the US now for the last 14 years. And each of those cultures, I have to really adjust my interpersonal style a little to fit better with the culture. So I do think that's the next frontier, and a great question to ask.
Thank you. No, I can't. It's another reason to bring it back, I guess, right? No, it's interesting. It's interesting too that I'm assuming that has to affect our view of ourself and who we think we are and our identity. It reminds me of what was his name? Tashfeld, who did the social identity theory a while back ago, and how complicated.
Yeah, I don't know that theory, but I do think what the alternative model for personality disorder has done for us is that it opens up the pathway to really make use of basic personality theory in a much more effective way. And for the first time ever in conceptualizing personality function. And something like social identity theory would be very important. So all the social psychological theories we can begin to look into to elucidate how we see identity function also in personality disorder. Before the alternative model for personality disorder came along, it wasn't really possible we really saw people as disordered or not. And we couldn't have the crosstalk between basic personality theory and research and maladaptive personality theory and research. And these bridges are now being built. So we're at a very exciting time.
Wonderful stuff. Wonderful stuff. Thank you so much, Dr. Sharp, for being here.
No problem.
Thank you, everyone, again for following us. Make sure to share and subscribe. Dr. Carla Sharp, you can look for information on her and her studies. You can go to the website. Actually, I think it's the university website over there, uh.edu, and you can find out all her studies. If you want to get more information about this topic, make sure you hit that like button, folks. Thanks for listening.